transplant it to his hand so that he has grasp. So that's basically what I have been doing during my career. But I have also had some experience abroad, working in a variety of different countries in burn care, cleft lip and palate, and also in microsurgery. My experience with domestic violence has been quite limited, to be quite honest, in Canada. I grew up in a very small town and did not see much overt domestic violence until I became a resident in surgery and saw this young woman in the emergency department who had been viciously beaten by her husband with a hot frying pan and massive burns inflicted on her. I've also been the physician looking after a little boy who was tied up by his feet, swung by his parents, and pushed with the lighted cigarette from one side of the room to the other. The abuse that I have seen in acid burns has been limited, fortunately, but I did have the opportunity to try to help out a little boy who answered the door at a wrong moment. When his father's enemy was knocking, the little boy answered the door, and the little boy got splattered with the acid rather than the father. So these things happen. They happen all over the world, and they happen far too often. The speakers have outlined a number of different things so far today, and I'd like to just touch on an area that is very important to me, and it involves the collaborative use of healthcare facilities and healthcare personnel, and the concept of comprehensive care, where a number of different subspecialty or subdisciplines work together for the overall good of the patient. So much like the epiphyte on the left, who does not damage its host, so we can work together. And like the honeybee, the different forms of honeybees, the queen, the drone, and the workers, they all have their independent jobs to do, and they do them separately, but in a collaborative way so that the end result benefits all for the survival of their species. Next slide. Well, what about collaborative and comprehensive health care? And let's look at burns, which is an area that I'm quite familiar with. There's no way that one individual surgical procedure can lead to a positive outcome in burn care. We need a team. We need a team of nurses. We need a team of rehabilitation people, occupational therapists, physiotherapists, in order to avoid results such as this. These are the sorts of things that can happen when there is no comprehensive care, when burns are allowed to heal and to contract and to deform without the aid of the rehabilitationists and a comprehensive team. So we need to work together with teams, not just isolated surgical procedures, but with teams that have therapists, and particularly teams that have social workers and people that are able to address the psychosocial needs of these patients. This is the outcome on the girl on the left. She's not happy. This has not been a positive outcome, even though from a surgical standpoint, she is healed and she is now able to go back into the community. Her psychosocial needs have not been met, have not been addressed, have not even been touched. I have had a great deal of experience in cleft lip and palate and in dealing with the cleft lip and palate patient. And it's not just as a surgeon, I can repair the lip, but it's not just the lip and palate that are important. It's the overall person, and we must take a total holistic view of these people and address their psychosocial needs, not just the physical cleft that we can see, so that we have an outcome that you can see on the bottom with a happy child, happy mother, and a cohesive family. In the cleft field, we need not just surgeons, but we need social workers, we need psychosocial people, we need ENT, audiology, and particularly speech, and this is an area where we fall short around the world, and I'll talk about this in a second. Next, please. This is an example of multidisciplinary care that can be done with our speech pathologists, working in conjunction with our ear, nose, and throat colleagues and our audiology colleagues. And let's look at microsurgery. Again, in microsurgery, one cannot work in isolation. We have to work as a cohesive team with our rehabilitation people and with our speech people and with our psychosocial people. So this little girl, for example, who has a unilateral facial paralysis, the next slide, please. We are able to make some markings, take a muscle out of her thigh, as you can see in the gloved hand, transplant it to the face, reconnect things, and have a happy patient. But we need to have the psychosocial component as well to support this young girl. We need to have speech pathologists, occupational therapists, and working as a family unit together. So it's not just surgery that can do this. The literature has a great deal of information and a great deal of support for comprehensive care. It's shown to lead to better outcomes from a surgical standpoint, better patient satisfaction, and there are even some studies that show that it can reduce costs. So I would encourage all of us to try to work in a team setting, as you can see here, to try to deal with the overall needs of our patient population, particularly in the cleft area, which I am most involved with. Here's another example of how comprehensive care can help this adult who never would have had his surgery if it couldn't be done under local anesthetic. So we did this with a child life specialist holding his hands, talking to him while we went ahead and did the surgery. I work with an organization called Transforming Faces. It's a small NGO in Toronto, and we try to promote multidisciplinary care by facilitating transportation and facilitating an overall unit that will deal with all of the needs of these children, be they psychosocial, ear, nose, and throat, hearing, particularly speech, and work with the surgical organizations that will deal with the surgery itself. So we try to have a comprehensive overall unit that will deal with these types of problems. And our model, I think, can be transformed, again, into a more generalized form. We'd like to prove this model, and then we'd like to take it forward regionally, nationally, and then internationally, so that comprehensive care will become the standard of care for cleft children. And we can see here a speech camp in Thailand and our overall psychosocial support system looking after this little girl as well. So what does the future hold? I think the future holds tremendous opportunities in healthcare, in individualized healthcare, but not dealing with a physical problem, but dealing really with the person. And if you look at this little boy who I just operated on last week, he has what's called Mobius syndrome. He has no muscles in his face. But during his preoperative evaluation, you can see in the bottom left his parents, the anesthesiologist, and he's in bed with his support dog. So we're thinking about not just the physical aspect of that person, but also his psychosocial needs. He has autism, would never have gotten through this procedure without his friend, the dog. And you can see him post-operatively on the right with his dad and his good friend, who helped him through this trying and very difficult procedure. So I would like to focus attention on not just the physical deformity, but trying to move forward to something that perhaps the UN can help us with, to identify the problems that exist in small pockets of care. Secondly, to try to look at what we can do. And then thirdly, try to get some innovative concepts as to how to deliver this type of support system where it is not available. If it is available, no problem, let's just go ahead and do it. Where it's not available, let's be imaginative, provide for education, and in areas like speech therapy, which is a very, very difficult area throughout the world, let's be innovative, define what we actually need in a very focused way, train lay individuals to do this, set up a program where we can deal with the needs of these patients, be they remote or be they close. No matter where in this world we are, speech therapy, particularly in the cleft child, is a deficiency. And after that, we can look at what we can do as a unit and how we can fund these how we can fund this type of care so that we can then provide this type of care which is not available to the patients who need it the most. For what we absolutely want is a healthy, happy outcome, as you can see here, be it in the burn field or be it in the cleft field. So I'd like to thank you for giving me the opportunity to come here. It's very much a great honor for me to present this concept of comprehensive care to such an auspicious group, and I hope that we can later make some arrangements to perhaps pursue this in greater detail. So thank you very much for the invitation.
Thank you so much. Thank you so much, Dr. Zucker, for that very